The straight leg raise test is a test advocated for radiculopathy and or discogenic related pathology. It amazes me how many people still continue to struggle with performing this correctly. The test is, so typically the patient's supine and just have them relaxed, and I always ahead of time before I do the test is teach them how to put their hands behind their head, and then when I ask them to bring their chin towards their chest. Now this is going to be part of your bias. So remember, to make to have the test be positive is it has to reproduce their symptoms. It has to be different than the other side. And so we're going to assume that the left side is the side that we're testing here for concordant pain. So it has to reproduce their concordant pain, number one. Number two, it has to be different than the other side. And then number three, it has to be affected by a component that is distant, D-I-S-T-A-N-T, from where their symptoms are. So this is why I like using the head as a distant, because by using the foot it can be a little bit complicated, and we'll go through that here in just a second. So as they go through it, so when you're going to do it, so you teach them ahead of time, you have them do it independently, and then what you're going to do is you're just going to passively straighten their leg up. And so this hand, consider if somebody's going to have pain, what they're going to do is they're going to try to get out of it. So you always want to try to block motion. So with this test and the slump test and similar, your upper limb tension test, they're all similar, where you want to try to block compensated motions. Compensated motion here is going to be knee flexion. So my hand is above the patella, keeping the knee into extension. So just not really forcing it, but just not letting it come up. You don't want the thigh to come into flexion without the knee or without the shin. So all I'm doing is maintaining knee extension. And then with my left hand, my caudal hand, is I'm raising the leg up. And all I'm going to do is raise their leg up as far as they can until they have some symptoms or I get to wherever I can go. So let's say that's as much extensibility as he has, or let's say his symptoms come on there. So then what I want to do is I want to bias that, because I want to know, okay, is that his symptoms? And I can ask that. And I want to know, was it different than the other side, and is it affected by a distant component? So I can ask if that's his symptoms. I can ask if it feels different than the other side, but I need to bias with a distant component. Now I definitely could use the foot, but let me go through the head here first. So what I do is I lower it down. So I lower it down to point where he no longer has symptoms. And then I ask him to raise his head. So I go back and I block the knee, he raises his head, and if his symptoms come back to what they were, so I raised it up until he had symptoms, I lowered it down until the symptoms went away, and if he raises his head and the symptoms come back, that has to be either neural tension and or radiculopathy. If it was neural tension, it's probably going to be similar on either side, so it's not truly a positive test for radiculopathy or discogenic. If it's thought to be a positive straight leg raise test, is it will reproduce concordant pain. Like I said, it will be different than his right leg, and then this, raising his head from a lower position, will affect his symptoms. Now if they have neural tension, that could come back too. So that's why you need to know, is it their symptoms, number one, and number two, is it different than the other side? If it's not their symptoms and it feels the same as the other side, but the head moving up brings it on or brings it back, it's probably neural tension, and we all have some degree of neural tension. So again, that's what you want for a positive test. Now I could use the foot, and so I could use the foot. So let's say I lower down to here, symptoms go away, and I dorsiflex the foot. If I do that and it recreates something, I need to figure out the first two things, right? Is it their symptoms, and is it different than the other side? And sometimes and it's not always clear. Sometimes that's not always straightforward. So that's why I like using the head. The other thing is, imagine if he has calf tightness. If I lower him down to where it goes away, and I dorsiflex his foot, and the calf tightness comes back, is that calf tightness? Is that neural tension? Is that so-called radiculopathy? If it's calf tightness, it's going to be tight whichever amount of hip flexion he has. So one thing I could do, so you can still use the distal, you can still use the foot. You just need to play around with it a little bit more. So if his symptoms come on here, then what I would do is I would lower his foot all the way down to the table, dorsiflex his foot, and see if it's the same as what it was in this position. Calf tightness will feel the same regardless of where he's at. And you can have it with stretching his calf and stuff. Neural tension and or radiculopathy is going to be affected by head movement and or by the hip flexion component. If it's tight hamstrings, what I could do is bend the knee, bring him up to 90 degrees, and then try to straighten the knee and see if it feels tight again. Or, so it's, the point is that you need to discriminate, is it soft tissue tightness, or is it neural tension, or is it radiculopathy? The nice thing about radiculopathy is you have other hard signs that are supported even stronger. So decreased reflexes, decreased sensation, decreased myotone. That's why, those are the things that you need for true radiculopathy. So if we play this a little bit more, and so we go and kind of look at it a little bit closer here. And so this is a little bit of a close-up. Again, blocking the hand there and lower it down to where he doesn't have symptoms. Now, I don't know if you saw what I did there, but so if straight sagittal plane motion doesn't get it, but you're still suspicious that they have some stuff going on, lower them back down. Okay, so even if he's here and he has no symptoms, lower him down to where there would be less tension, and then bring him into adduction. So I'm adducting him, and I'm internally rotated. So if you saw the adduction and internal rotation. What that does is the sciatic nerve, as it comes out behind the hip, is it's lateral, and then it goes to medial. So adducting biases the sciatic nerve, internally rotating biases the sciatic nerve. And then from that adducted and internally rotated position, I can bring him up into deeper hip flexion. So this is just more of a bias. So you would not do this if straight sagittal plane bothered him, because sagittal plane is less provocative than adding this. The only time you would do this is if you want to make sure that they don't have it, and especially if you're really suspicious of it. So that's something you can play with there as well. And then this is not really part of it, but this is something that you can kind of consider here as well, and just biasing the different nerves. And so the cord is meant to kind of look at the different nerves. So you can play with biasing the different nerves. So the tibial nerve, the sural nerve, and then the peroneal nerve. So in this case, we have the tibial nerve. So as it runs across, it runs posterior to the malleolus. So therefore, I have to dorsiflex the foot, which is going to stretch it. It runs from medial across to lateral. So therefore, since it's posterior to the malleolus, I have to dorsiflex to stretch it. Since it's medial to midline, I have to evert to stretch it. So to bias the tibial nerve is I have to do dorsiflexion and eversion, which is being shown here. So see how that stretches there. So dorsiflexion stretches it, and then eversion stretches it as well. So tibial nerve is you want to dorsiflex and evert. And to bias that, you can do that even before you bring them into sagittal plane hip flexion. These are not part of the traditional straight leg raise test. These are just additional things that you can kind of play. Because, for example, if somebody came in with shin splints, this would be an option to figure out do they have shin splints or tibial nerve issues. But this is a little bit more advanced, and this is not something we typically always assess for. So now if I look at peroneal nerve runs lateral, so therefore I have to invert, and it runs posterior to the lateral malleolus, so therefore I have to dorsiflex. So to get peroneal nerve is I have to dorsiflex and invert, which is being shown here. So you can see how that stretches the peroneal nerve. And I don't have on here, but the sural nerve runs across the front and is a little bit, so sural nerve runs kind of like this. It's anterior to the malleolus and it's lateral. So therefore, since it's anterior, I have to plantar flex. Since it's lateral, I have to invert. So the combination of plantar flexion and inversion will stress the sural nerve. So that's how you can use those different motions to bias the different nerves and figure out which one's the issue. All right, statistically, even though this is a test that I like to use a lot, it's not overly impressive. It really only has a small shift in pre to post-test probability. So, it's essentially a screening test. High sensitivity, very poor specificity, and so that's much stronger as a screening test. But if you plug in the likelihood ratios, it essentially is still only a small shift, but highly precise. So we tend to utilize the straight leg raise test and the slump test, which we'll talk about later, as screening test, not really diagnostic test. Now the cross positive straight leg raise test is a good ruling in test, but the traditional straight leg raise is a screening test. All right, everyone. I hope you found this helpful. Take care.